Hi, and welcome back to Healthcare Simplified with Manpreet Richter. It has been a little bit of a hiatus that I've taken. Obviously, I did not go and get my shingles vaccine, which ended up with me getting Bell's palsy. So now I'm back, hopefully stronger and better and all these things. But on the show today, we're going to talk about an equally important subject that everyone has really not touched on, really. Is our public health care getting better? Or is it getting worse? I don't know. In the studios with us right here today, I've got two very important guests. Very, very difficult to get them. And we managed to do that just for you to find out more. Furthest away from me, I've got Dr. Jeyakumar Devaraj. Doctor, you are the chairman of Party Socialist Malaysia. Welcome on Healthcare Simplified.
Thank you. Thank you.
And over here, a very good friend of ours of the podcast here, we've got Prof. Amrahi Buang, who is the president of the Malaysian Pharmacists Society.
Yeah.
And I personally communicate more with pharmacists than with doctors, and I find that the system that you guys have got is very, very good. Welcome on the show.
Yeah, thank you
Okay.
for the invitation. Yeah.
Well, we're talking about healthcare in Malaysia as opposed to every other country in the world. And, the world has changed, Doctor, and we get to see a lot about what is happening everywhere in the world, healthcare in America, South Africa, wherever it is. And on Vital Signs, we do share all these things. So I was very intrigued when I saw that your party, Party Socialist Malaysia, which is a political party here in Malaysia, and you've come up with this brochure pamphlet, come up with this entire campaign which says, Save Our Public Healthcare System, right? So I want to talk to you a little bit about that. When you say save, obviously something's wrong. So maybe you want to elaborate a little. What's wrong and how do we save it? Tell me.
Okay. Very simply, I can touch three things.
Okay.
Actually, you've got a very good healthcare system.
Okay.
I think we should all be proud of and try and preserve. But it's being threatened by three issues.
Okay.
One is this Rakan KKM scheme that the government seems very intent on implementing.
Okay.
And we feel that will take away attention from the non-paying patients, from the really poor patients in the government sector. That's one. I can go deeper into that.
Okay.
The second major thing is there is a whole rash of private hospitals coming up. And
Okay.
the government is not regulating them. And so you get so many coming out. Each time a private hospital comes out, they kind of attract 15, 20, 30 specialists from the government side.
Of course.
And then the government side gets even less specialists, the senior specialists to look after the patient. So that's a major thing because now it's a lot of health tourism, it's big bugs,
Right.
So there's a huge brain drain aggravated by these private hospitals. That's number two. And the third thing is that we are chronically underfunding our healthcare system.
Okay.
We're spending only 2.3% of our GDP
Right.
on the Ministry of Health. Even Thailand spends 3.9%.
Okay.
Of course, you talk of UK spending about 9% of the GDP on the healthcare. So we are actually grossly underspending, and that's why there's so much of, congestion, long waiting lines, and not enough, MRI machines and all that. So these are the three main issues.
Okay.
And I think we need to address them
Okay.
to save our healthcare system.
Okay, so you guys have come up with this campaign. You're talking to people. You've gone out to the crowd. You're doing that. First, let's get into that first point of yours about Rakan KKM. We've all gone online and we've looked at the website. It looks like a good idea, but the devil's in the details. We don't have enough of that. Why do you think it's not a good system itself?
Well, we think it's a very bad idea.
Bad idea. Okay.
Very bad idea. You see, the thing is, if you look at all the specialists in Malaysia,
Right.
who have got more than 5 years of experience,
Okay.
those with bit experience, 5 years and more experience, only 25% are now in the public sector.
Okay.
75% are in the private sector already.
Okay.
If you look at hospital inpatients, about only 25% are in the private sector, 75% is on the government side.
Okay.
So the government side has got much more workload, but much less senior specialists.
Okay.
It's already bad.
Yeah.
So now if you open a wing or a set of clinics where you ask the government specialists, you go there, you're paid, you're distracting away, from looking after the other patients who can't
Okay.
afford to pay.
Right.
And even already now, you send a patient for a urologist, say in Ipoh GH.
Sure.
The urologist now has left and gone to the newest hospital, Sunway.
Right.
This gap is a long time already.
Right.
Now, do some of this,
Yeah.
the gap, So for seeing an oncologist, for seeing a cardiologist and all that, the time now in Ipoh GH is like sometimes 3 months, sometimes 6 months.
Okay.
You just see them, not even get the surgery done.
Right.
And that's going to get worse
Right.
if you have more Rakan KKM and more clinics and you try and pull more people. You see, Rakan KKM is also a means for the government to earn money. You're asking the health ministry,
Right.
you generate your own funds. We will give you 46 billion. That's your fund from the budget. You raise another 10 or 15 billion from your Rakan KKM.
Okay.
Okay? So the volume of work that's going to take place there to raise that kind of money means their doctors are going to be pulled there.
Yes.
And they can earn a lot.
Yeah.
They can earn as much as their salary when they are, the total monthly salary.
Sure.
So it's a big pool, you see, because your monthly salary is already fixed.
Yeah.
Here you earn as you go. So you are tempting them to go away, and then not all can afford to go that side.
Of course.
Our B40 definitely are going to be stuck on the government side.
Yeah.
And they'll be seeing the MOs, and the MOs won't have the specialists referred to too much because boss is that side doing something.
Sure.
So this is a bad idea. It's going to make things worse
Okay.
for the bottom half of our population.
Okay. So I'm going to jump in and ask Prof. Amrahi, even though you guys manage pharmacists, you do this thing, I think you're part of this healthcare team.
Yeah.
Me as a patient, obviously, I go to a hospital, there's an entire universe, there's an environment that helps the patient walk out. Pharmacist is one important cog in that wheel. Now, as a system, what do you think about this Rakan KKM and what Dr. Jaya was
Okay, I
talking about?
think we have to understand why it has been done or why the minister actually have decided on this.
Okay.
But I'm looking at a greater picture,
Okay.
meaning that look at the healthcare system. We haven't changed our healthcare system since Merdeka. Meaning that it's still a dual system where you have your public and the private.
Yeah.
And we always say that, if there's public, after
Right.
the private, if you have money, you go to private,
Right.
right?
Yeah.
And this has been going on and going on and going on. Maybe initially, okay lah, right? But as things changes, lifestyle changes and so on,
Sure.
and you can see the private sector are moving and so on and so forth,
Right.
we can see the shift.
Okay.
The shape. So, if taking for the point of Dr. Jaya regarding the concept of Rakan KKM,
Okay.
I can only share my little experience.
Okay.
Okay. Previously, I actually worked in University Malaya Medical Center.
Yeah.
All right. And yes, we are actually a statutory body.
Yeah.
Okay, and somehow or other we are able to do things that's not being done in any government setting lah.
Okay.
Okay, so because of that, how do we stop all this brain drain from UMMC to the private?
Okay.
Right.
Right.
That is the thing, isn't it?
Yeah.
So we come up with the Specialist Center,
UMSC.
UMSC. Yeah. Of course, it's not something that we did it because of the fact that we don't want to have brain drain lah.
Okay.
But we have a different sort of concept, meaning that it still belongs to UMMC per se.
Okay.
Okay, it's still within the system.
Yeah.
We are just offering, okay, the balance so that we don't lose the brain drain.
Right.
But at the same time, they're still around there.
Okay. Yeah.
They're still around there.
Yeah.
I mean, they have the inpatient, they have the outpatient.
Yeah.
So the patient have a choice.
Yes.
Okay, and it's open, When I say it's open,
Yeah.
meaning that the public has a choice.
Right.
Okay, all right. But the way we did it was the fact that, when we say, okay, we want to provide the private service,
Okay.
everybody that involved in that area
Right.
must be paid.
Must be paid. Okay.
Even the attendant,
Of course.
everybody,
Yeah.
everybody that provides service to the specialist
Yes.
must be paid.
Yeah.
Of course, it depends on how the state is on. Say how many hours that they work.
Sure.
So we pay like that. Lah.
Right.
Okay. And we know that we can have our own fund, we can create our fund. So in terms of legality,
Right.
we can still do it.
Okay.
For example, from the pharmacy point of view, right? Of course, we have to cater for all this, right?
Sure.
So we need, because we can have the fund and then we can use the fund, blah, blah, blah. Lah.
Yeah.
Right. So the whole idea is basically because I think UMMC also face the same challenge that,
The Malaysian public healthcare system.
meaning that, long waiting time, blah,
Yeah.
blah, people want to see, blah, blah, blah. Lah. Okay. But at the same time, there's that window opportunity.
Yeah.
So the doctors or the specialists are given time,
Okay.
to be in that, and it's not question, right?
Yeah.
So I think we can explore that as a system, but I don't think Rakan KKM is the same. Even like what Dr.
Jeyakumar, yeah.
Mentioned about the other one, the private wing.
Yeah.
But that one is it's only the doctors are getting it.
Yeah, so we were
so
alluding to the full paying patient,
yeah.
the FPP system, which is currently there.
So we are talking about actually one of the most challenging one is actually the out of pocket, the OPP.
Yeah.
That we are concerned,
Right.
So that's why these are the difference between, say, for example, the experience that we have in UMMC versus MOH, for example.
Right.
Say in a pharmacy, for example.
Right.
You see, previously when we start in the 60s
Yeah.
with that hospital, right from the very beginning for OPP,
Out
out of pocket, they will still pay, but not like government lah.
Sure.
RM1,
Yeah.
and then RM7. We will say only for medicine. Yeah? At that time, is for a supply, say 1 week, for example.
Okay.
So you only charge for 1 week, RM5, for example,
Okay.
for 1 week. So if it's for 1 month, then you multiply by 4 based on duration.
Okay.
Okay.
Right.
But as the formulary become complex, the UMMC is actually doing research,
Right.
and so on and so forth.
Sure.
New drugs, clinical trial, blah blah blah. So how when they finish their things, how to actually continue the treatment?
Right.
Because during the clinical trial, it works,
Yes.
right?
Right.
So we ourselves, offer ourselves, to the hospital to do this and to do that, so that at least there's continuum of care, even though after the clinical trial.
For the
And-
patient.
Yes.
Yes.
So of course they will pay lah.
Yeah.
Okay. So but the most important thing is that when we work with the industry,
Yeah.
the way we operate is the fact that we're not talking about making profit. We are talking about, because when you talk about managing medicine, it's
Right.
the same.
Yes.
Whether it's RM1 or RM1,000, the management
Yeah.
is still the same.
Sure.
So what we did is actually, if the drug worth 1,000, for example, so you only charge 1,000 plus administrative cost.
Okay. So that's the formula that you
Okay.
guys had. Yeah.
So we're not talking about 100% of the drug.
Sure.
And so on.
Okay.
So with this sort of thing, we thought that that we're helping the patient. I'm sure
Sure.
we can get more
Yeah.
more detail from the different. I think the specialists all happy
Okay.
and open. So I do not know how the Rakan KKM going to work.
Neither do I.
So I'm not too sure.
Neither do you, I suppose.
I'd like to come in on what he said about the brain drain.
Yeah. Okay.
Could I go on that? You see, if our idea now for the brain drain is that you have a moratorium on new private hospitals.
Okay.
That means existing ones, we leave them as they are. They already put in capital, they're already moving, they're already giving service, you leave them. But the new one comes along and says, one of the new chains, KPJ or Pantai Putri or IHH, say, I want to open another one. Say, hold on, don't.
Okay.
Reason being, see, like just recently in Ipoh, we had this Sunway Medical Center opened up.
Okay. Yeah.
When it opened up, 12 specialists from Ipoh GH
Move there.
moved over there.
Right.
And what I heard from some of the specialist friends is the officials from the Sunway come and tell you, hey doc, come over. We guarantee you a top up to 70,000 a month
Yeah.
for the first year.
Yeah.
After that, you're on your own. You get enough clientele, you're on your own. But the first year, I'll give you 70,000 a month.
Yeah.
These doctors are only getting 10, 15, they are
Sure.
media level, about $50,000 a month. You talk about $70,000.
This is huge.
Huge.
Yeah.
You see, if a private hospital comes in and it brings in, trains its own doctors and brings them in, I wouldn't
Well
mind.
and good. Yeah, okay.
But here you are doing it
Yeah.
at the price
Yeah.
of the public hospital.
Right.
I know for a fact that the oncologist went off from UPGH, the urologist went off, the cardiologist went off.
Okay.
Then you got to have urologists coming from KL or oncologists coming from KL to cover once a month, or twice a month. So what we're saying is, telling the government respectfully, why don't you just have a moratorium?
Okay.
Not saying the new ones. Not saying the existing ones.
Okay.
But the new ones for 5 years, you hold on.
Okay.
Let the government restock its specialists.
Right.
There still will be people going out, but not at the same pace. Because here they're actually actively drawn out.
Of course, yeah.
This hospital, the 12 of them are from Depot GH. Another 4 are from other government hospitals.
Around.
So 16,
Yeah.
So, that's one hospital. And it's just now, and not sure how many more they're going to pull in,
Sure.
see? So we're saying, and this has no cost to the government.
Yeah.
It costs the government nothing to say, look, moratorium. Of course, the government, sometimes the government doesn't know which hat it's wearing, because the government is also the owner through PNB, through Khazanah, through various things.
Of the private hospitals.
They own the private hospitals,
Yes.
through the GLICs.
Yes.
So they're getting some income there as well.
Yeah.
So I think they're a bit confused.
Sure.
Are they private or are they looking after the public?
Yeah.
But I think here it should be very clear. At this point in time,
Right.
only 25% or even less of the experienced specialists, those with more than 5 years experience, are in the government sector.
Okay.
And their workload is at least 3 times
Okay.
that of the private sector.
Okay.
They're already overloaded.
So I just want to very quickly explain this, right? Because Prof. Amrahi brought this up. So UMMC, which is University Malaya Medical Center, and University Malaysia Specialist Center, UMSC. Now, in Malaysia, we have a 2-tier system, public system and a private system. Now, in the public system, you have your Ministry of Health hospitals and you have your Ministry of Higher Education hospitals. Those are the UITMs, the UKM in Bangi, the PPUM, UMMC, all this. So they have 2 different systems of charging patients for services. And then within the second system that we're talking about, the UMMC system, they decided to, because of the brain drain, fix that issue and set up this entire entity. So if you've gone to PPUM now, you'll find there's another building in the back, UMSC. Same doctor from here goes over there, he sees you, he charges you, whatever the charges are. So that is a private wing of a public hospital. Now, Rakan KKM is not that. There's no private wing. There's no separate building. There's no separate facility, OT, everything. So it's within this facility, which is, I think, one of the things that you guys are also
unhappy about.
Yeah.
Correct.
Because there doesn't seem to be that division. And, like Prof was saying, it's very clear that you understand everybody that works in this building gets paid.
Yeah.
Right?
Okay.
With Rakan KKM, so if I went in to do an operation and you are the doctor and you're the head nurse and whatever the team is, under the current full paying patient FPP system, which is in 4 hospitals.
More than that, almost 10.
Almost 10. But I heard it's been whittled down to 4 because of lack of staff. So under those 4 hospitals, I pay for something and it only goes to the doctor. Then the doctor is responsible to distribute it to the rest of the team. I don't know how I don't know how your tax system works with that, right? But in UMSC, it's I pay and you get a piece and you get a piece and all these things is very clear.
But Victor, that's not the main issue. The issue is not how fair you are to the doctors, nurses, attendants.
Right.
How fair are you to your patients.
Exactly.
The issue now is the government healthcare system is meant to provide services of healthcare to the people.
Right.
Okay.
Now, if you're telling the government healthcare system, you earn your own money.
Okay.
Part of your own money. That is wrong. That is not their job to earn the money to finance the system. That's what now YB Zul is taking on that responsibility.
Okay.
Okay, you give me 46,000, I'm going to raise another 46 billion, I'm going to raise another 10 billion. That is not really the job
Of the Minister of Health.
Minister of Health or the Ministry of Health. The Ministry of Health is to give good services.
Right.
The Ministry of Finance should look and see with this rich country,
Right.
why can't we allocate more health?
Okay.
So to focus it on are we paying the attendants correctly or not, that is not the issue.
Okay.
Even physically, if you can have build a separate wing and do it, it's still wrong.
Okay.
Physical separation is not the issue. The issue is you're short of specialists in the government side.
Okay.
And you're going to distract them with this full paying scheme,
Right.
You're going to get paid and you're going to distract them. That is the issue. And the poor fellow from the kampong or from the estate
Right.
or the squatter area or from the PPR housing
Yeah.
who goes there will not be able to see a specialist.
Okay.
That is the issue.
Yes.
Please focus on that, but not whether attendants are being paid or not.
Okay.
You know?
But is there...
Yeah.
Sure, go ahead.
Now you look into I think when the Dr. Jaya mentioned, we have to accept that, that our healthcare system is as such as has not changed.
Yeah. It hasn't moved on. Yeah.
Even if we look into even among the Commonwealth countries, say we say we inherited all this from UK and so on
Yeah.
and so forth.
The NHS.
But people have gone
Far ahead.
a lot. Like you in Australia is different, in Canada different, blah blah blah, right?
Yeah.
So my question is like this, okay? We are still seeing people saying that, okay, we do not want to change, for example.
Okay.
But I did mention earlier, isn't it?
Yeah.
The thing have changed.
Yes.
Okay, the thing have changed. And because of that, then you go back to the thing that you mentioned about universal
Healthcare.
coverage. How you define
Yeah.
universal health coverage if the definition only says for the public sector,
Yes.
everybody have access. That is not universal.
Okay.
Because of the fact that, because of the long hours,
Yeah.
or waiting time.
Yeah.
The waiting time can be months.
Yeah.
And in some area, can even more than a year,
And
So
the wait-
so you go back to the issue of access.
sure, the waiting time will be increased
Yeah.
by the fact that you don't have enough specialists and they
Exactly.
move across. Yeah.
Yeah.
So, is there a system, a health system in the world that we need to look at and say, that is something that we should model some things on? Prof was talking about this universal healthcare, where in most countries in the world where they practice universal healthcare, it is every month I'm paying X amount, whether it's 20 ringgit, 50 ringgit, 100 ringgit, whatever, or a percentage of my salary, which goes into the system. And it goes into the healthcare system, whether I use it or not. So eventually it helps sustain, the system. Is there a country in the world that we should look at and say, this is some system that we should try to emulate or something like that?
Maybe you won't like my answer. I'll say, look at Cuba.
Okay.
Yeah,
Look
right.
at Cuba, because Cuba
Yeah.
is very much primary healthcare driven.
Okay.
They have a whole set of GPs,
Okay.
and the GPs and their unit, the team and all that, they make sure they cover up everyone. Everyone must come for an annual checkup or biannual checkup, twice a year. And they make sure your weight is okay, check your BP is okay, check your
Right.
cholesterol is all right.
Okay.
So, the life expectancy in Cuba is, I think, equal or better than America.
Right.
I
Okay.
mean, they're a poor country.
Poor
Due to
country.
Sanctions and American blockade and all that. But they were one of the countries that came out with the COVID vaccine. They had their own COVID vaccine because they knew this fellows would sell to them.
Yeah.
They did their own COVID vaccine. They
Yeah.
had their own COVID vaccine.
Yeah.
So, I mean, I would think that's amazing, with that little support they had.
Right.
Small country of about, 15 million?
Sure.
And they can have their own vaccine, and they have some of the highest rates, infant mortality is one of the lowest, better
Right.
than many countries in Europe.
Yeah.
Diabetic better than countries in. So I think that is one thing. The other thing is talking about paying. Why are we getting so business? I would say, look, in Malaysia, our minimum wage is what now? 1,700.
1,700. Yeah.
The minimum wage in California,
Yeah.
in Malaysian ringgit, is about 12,000 a month.
Okay.
So the person's working in a factory doing, say, chips, electronic chips in
Right.
California, doing the same chip, the same factory has come to Malaysia. Here we get maybe about 2,002 or something.
Right.
There we're getting about 18,000 Malaysian ringgit,
Okay.
about 8 times more,
Right.
So basically, I will make the argument
Okay.
that the workers in Malaysia are taking a huge cut in their salary for the national economy to pull in foreign investment, so we can have jobs, we can have investment.
Sure.
So the working class in this country is sacrificing. They're not asking, look, pay me what they're paying for the same
California,
work
yeah,
in
yeah.
California or in
Yeah.
Europe,
Yeah.
So I think we're paying that way already, you see.
Okay.
So it's part of the social contract.
Right.
The fact that we cannot actually, we are in a situation where if we actually double the wages of all our workers,
Yeah.
it'll be suicide for us at this point in time.
Sure.
Because we'll get cheap goods coming in from, say, Thailand,
Yeah.
and Vietnam, and our local manufacturers will just go down.
Right.
And our exports to Europe and all that also will be priced out of the market.
Yeah. We need to be competitive.
Yeah. So we want to be competitive. We're asking the working class to sacrifice and continuously sacrifice.
Right.
Give them free healthcare lah. What is thing? Pay.
Right.
That's how we look at it lah.
Okay.
You're already, they're sacrificing so much.
Right.
Give them something. You must subsidize healthcare.
Right.
And the other thing I must tell you, Mr. Victor, is that we look at our GNI, gross national income.
Right.
Gross national income, the whole amount. The amount going to 90% of the population
Right.
is only about 28%.
Okay.
The whole GNI
Right.
is going to 98% of the population. Talking about the workers, the farmers, the small businessmen,
Sure.
the gig fellas, everything, 90% of the population only get 28%.
Okay.
16% is government taxes, government income.
Right.
56% is the largest companies and the richest 10%
Okay.
of the country.
Right.
56%.
Right.
You're saying, look, take a bit of that
Right.
and put it into government
Right.
and have good social welfare programs. You have a good healthcare program, have a old age pension program,
Okay.
public transport program, free education program. You can do all that. We just take a bit of that money, not all of it. I'm not saying take away all your profits. No.
Sure. Of course.
Just take away a bit of it, maybe 10% or
Right.
around that of it, and then put it into public service. And that will be fair. That is not robbing them, because these guys, our workers, our 90%, are working at much lower incomes
Okay.
than what people are working in the West. For the same amount of work,
Right.
they earn so much less.
Yeah.
So we think that's what the social contract should be. And it's not charity. It is not even enough, actually. But,
Right.
I say we should do that, is it?
So everyone
coming
gets to give a little piece for the people who are right down at the bottom doing the work, actually doing the work.
Yeah. The 90% who are holding up the economy,
Yeah.
if they get subsidized healthcare,
Yeah.
it's just fair. So to talk about, they must pay, every month they must pay, they're already paying them so little, your wages are already so low.
Okay.
But I'm saying, I understand why the wages have to be low.
Yeah.
Because if you push it up too high,
Right.
we won't get FDI. Even our domestic investors will go and invest in Thailand,
Sure.
because
Yeah.
you cannot, you can't compete price-wise, you see.
Sure.
So,
Okay.
so
You want to jump in? Yeah.
So the reason is like this. I can understand because you see after actually I become the president of MPS
Yeah.
after I retire already. So it's had been what, more than 10 years.
Okay.
So meaning that when I came out, because I'm in the system already, right? When
Yeah.
I came out, I have to learn what is going on with the healthcare system in this country. There are a few things that I go. I'm sure Dr. Joya made me in a lot of stakeholders meeting and so on and so forth. But let's go into facts.
Okay.
Right? You see, we have all these ideas and so on and so forth, and we actually come up with the health white paper.
Ah.
Whether people get to talk whatever it is,
Yeah.
it has been decided in Parliament.
Yeah.
Both sides of the political divide agreed.
Yeah.
Okay, and we are waiting for the details. Okay.
Yeah.
The point is like this: we have discussed, how to reform our healthcare system. Not new. I'm
Right.
sure Dr. Jaya know.
Yeah.
2 decades ago, 3 decades ago.
Yeah.
So what I'm trying to say now, we want to move forward.
Yeah.
We want to move forward.
Right.
So I think one of the main pillars is actually national healthcare financing.
Okay.
It's clearly stated.
Yeah.
So we want to know. Okay, we have discussed.
Yes. Yes.
We have discussed, and we see that it has to be done.
Yeah.
But after 2 years,
Yeah.
not being done.
Okay.
Okay, I'm not too sure what they're going to do next.
Sure.
All right, and this current government even left another 2 years,
Yes. Another 2
and
years.
so on and so forth.
Yeah.
Even if you look into the what you call RMK 13, for example.
Yeah.
All right, we can only say that within these 5 years, whatever they're going to cut, they will only concentrate on that sectors only. Health is Ministry of Health. But it's very clear in that health white paper is actually health with education is actually everybody have to play a part.
Okay.
Okay,
Good.
so we go back to the healthcare financing, right? I think the Tajaya mentioned about Cuba, for example.
Yeah.
I'm okay with that.
Yeah.
Right? But at the same time, there are also system that
Sure.
we can also adopt.
Yeah.
Okay, you can look into any other countries.
Yeah.
All right, so we can also look into this, but at the same time, we must agree lah. So I would say that we still need a national, whatever they call it, social insurance, a
Okay.
national
Health insurance.
health insurance,
Yeah.
NHI, right?
Yeah.
A national health insurance, all right?
Yeah.
I think that recently they mentioned about that hybrid, isn't it?
Okay.
Okay, they
Yeah.
mentioned about the hybrid, right? So, but what we are saying is that we are talking about universal health coverage.
Sure.
My wish list will be what the B40. They should get access to the GP
Okay.
through a system.
Yeah.
To the
Yeah.
health system.
Yeah.
It's not like currently now you put what PECA
Yeah.
before blah 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 what kesehatan madani whatever. You look, that one is really different. This one is a proper health financing system
System.
where everybody got access.
Okay.
Everybody.
Okay.
Okay. And even now, okay, if you look into all this type of insurance, and in Malaysia, of course, we have the private one,
Yeah.
including the takaful,
Sure.
and then we have Pekeso, right? And
Yes.
so on. All these are all things that we should amalgamate everything.
Right.
That means every damn citizen
Yeah.
or whoever in this country must have access to healthcare.
Sure.
So, if, for example, we do that, and the one thing about us, the same like say in Indonesia, for example, they have their own national health insurance.
Sure.
Thailand so got,
Yeah.
even Philippines so got, of course Singapore, blah blah blah.
Yeah.
So I think it's high time for us to really sincerely look into it.
Yeah.
And I agree with Dr. Jaya. The B40 must have access even in the private
Okay.
through this system.
True. This is.
So that's why when I say universal health coverage just now,
Yeah.
okay, this population be able to address
Okay.
to access
Yeah.
both in public and private.
Okay.
So you will ask me, isn't it?
Yeah.
What will happen? We have this national health insurance.
Yeah.
What happened to the private? If you want extra, you can go ahead with the private. It's fine.
Yeah.
It's fine. But this one is very important.
Sure.
When I say this, you know why? When you talk about everything, we're talking about two things in terms other than the health white paper. You go and look into the national medicine policy. It's very clear when you talk about access to medicine.
Okay.
But I don't think a lot of the stakeholders actually understand the national medicine policy. And I got to reiterate when I mentioned the word medicine security during the pandemic.
Oh, yeah.
One of the issue that actually came out during the pandemic was actually medicine security, and it's a classic case where you can even have paracetamol.
Yeah.
Okay, so I did tell the government, saying that okay, look into this, irrespective, anything can come in the future,
Sure.
big floods, anything happen, war, whatever. Please, you have to take care about your national essential medicine list.
Right.
Everybody must be able, because we are talking about something. So these are the things which I feel
Yeah.
that can be done lah. So as far as the expertise,
Right.
okay, as far as the expertise that we have, I think Prof is one of the things that
Side Arjunic, yes.
yes,
Inside even a
okay.
show. Yeah.
And he has done in Kuwait, he has done in other even in Indonesia, so on.
Yes, he has.
All right. So we already have things being done already.
Sure.
I'm sure we want to move, but sorry to say lah, if I'm not saying I've been negative to politician, what I'm trying to say, if they say education and health as political issues,
Correct.
then that is very difficult lah.
Sure. We're going to take a quick break, but I just got to say that we're going to take a break and then we'll come back, right? When you're talking about a health white paper, to me as a patient, I've heard this being bounced off the table every time when I'm asking questions, health white paper, health white paper, health white paper. To me, a patient, 2 years into having heard that word, it's not a health white paper. It's a transparent paper because there's nothing on it. It's not clear. I don't know what the heck's going to happen. And as a patient's going into a hospital constantly, it doesn't mean anything to me. When somebody turns around and says health white paper, but there's no action, right? So for us, as patients, as the public, it's absolutely transparent. You can't see it at all. We're going to take a quick break. We'll come back with more right here on Healthcare Simplified with Malaysian Richter. See you. Hi, welcome back to Healthcare Simplified with Malaysian Richter. We're on to the second part of this very interesting conversation just now about national health financing system, right? So, national health insurance. You mentioned Cuba earlier. If you Google best healthcare system in the world, probably France comes up. France. They've got a system where everybody pays a certain amount. Everybody who's working pays a certain amount. I think it's 50 euros or 70 euros a month. It goes into a bucket. It's kept there. If you're ill, you can go, I know everything is paid for. Now, if you want to now go to a private hospital, it takes care of certain the frills, you got to pay for it. So you out of pocket, whether you've got your own personal insurance. That's how that system works. Is probably one of the best in the world. Now, let's talk about healthcare financing. How do you think we should look at it? How do we in Malaysia look at it? How do we emulate a system and say, this is Malaysian, our neighbors are doing something? What do we do?
Okay, you see, the problem with this national healthcare financing scheme is that you're talking about social health insurance, which is much better than private insurance.
Yeah.
Okay.
You have social health insurance, it means you pass a law, like the EPF.
Okay.
And everyone has got to contribute to the scheme.
Okay.
How much you contribute is not based on your risk factors. You got diabetes or your family has got something. No, everyone pays. In some countries, like say in Taiwan and I think Korea, they got different tiers.
Okay.
You know, the richer people pay more.
Right.
Middle pays a bit less, poor pay even less.
Okay.
So that's the kind of thing. Okay, now if you do that, and let's say I'm in the upper M40 or the T20, and I've been going to the private all the while, you know, and then now you're telling me I must pay to this system. It would be unfair to say you can only go to the government side. I got to be able to take my money to both sides, right? So that will be fair, right? So what the government has come up with before this, working with WHO and all that, is they've come up with an idea that you got to corporatize all the government hospitals.
Okay.
So that means you can't make the private hospitals public.
Right.
So you make the government hospitals like companies.
Okay.
So all the government hospitals become corporatized.
Okay.
Then you have a system talking about DRG and all. How do you charge? So you have this national health scheme. It gets money from everyone, maybe some budget from the government, some syntax got that money, right? If you go have appendix and you go to the private, you get a certain amount of money. If you go to the government, that government hospital can also claim that money from the fund.
Okay.
So that means you shift from now, where it's just a global budget, you look after everything. It's a per capita now. Now it's that you go, you treat, they give you a global budget.
Okay.
You got to make the government hospitals operate like businesses.
Okay.
Like private hospitals.
Right.
Got to look at all the gauze they're using, how much anesthesia, how much medicine and all that. You're changing the whole system into a commercial-based, market-based system.
Okay.
You understand that?
Yeah.
If we do this, you got to put them both together. To put them both together, you cannot, you can't make the private public. So you make the public in a way private and act like companies.
Right.
Then it causes a lot of other problems. You see, let's say, look, a person comes in with pain in the right side, lower side. Okay, a young teenager comes in. Normal way we do it is we examine, we see this, and see whether it's appendix or not. Sometimes a lot of gray area.
Sure.
So whether you go in or you wait for a while more. So if a good surgeon will wait and see. If he's not really sure, he'll wait, but keep examining every 4 hours, every 8 hours, 4 hours, and then decide if things get, I better go in. And even then, you get about 15%, 20% white appendix. It wasn't appendix. You
Okay.
get in anyway.
Okay.
But you see, an appendix operation, you can probably earn 3 or 4 times as much. If you just sit on it and it turns out to be a lymph node,
Okay.
mesenteric lymph node adenitis.
Right.
You sit on it, it settles down. You don't have to go in.
Right.
How much can you charge the system?
I see. Okay.
So if I am the hospital administrator and Prof is my surgeon,
Yeah.
and he's being too careful and not going in, I'll
Right.
say, hey, do a few more operations,
I see.
isn't it?
Yeah.
Same thing for cesarean sections.
Okay.
See, many of these medical decisions, do we go in now or not? Is the child in trouble or not? It's something gray, It depends on your acumen, your gut feeling,
Yeah.
So if then you have a commercial aspect there, I can earn more. The hospital can earn more if I cut,
Yeah.
if I do an angiogram, if I do the MRI. So you're pushing the whole system into a more expensive kind of orbit, lah.
Okay.
So we are saying that this is not the way to go.
So that's not the way to go.
Not the way to go. Because if you want to have this common social health insurance,
Right.
means you got to integrate both systems, means you got to corporatize the government hospitals,
Okay.
means you got to make them run like businesses and charge for things.
Yeah.
And then it's going to have all these perversions,
Okay.
It's going to happen, you see.
Yeah.
So I think people got to think it through.
Right.
If you do it this way,
Yeah.
you're asking me where the money should come from. It should come from the 56% of
So that's
national income
Yeah.
going to the top 10%
Right.
and to the companies, the big companies.
Okay.
We should tax a bit more of that and use it for healthcare system.
So when you say go to the healthcare system, so you tax them,
Yes.
does it directly? So it doesn't go to MOF and put into the national bucket.
No, it'll go.
It needs to go straight into
No. I think it'll go to the MOF. It goes to the consolidated fund.
which is again.
No, the government agrees. The people agree, and the government agrees. You can give a higher budget. You see, our budget is low.
Yeah, it's 2.7%. Yeah,
2.3%.
2.3.
In UK, the budget is about 9-something%.
Yeah, and it's still not enough.
See, healthcare is never enough,
Yeah.
But we can do better than what we're doing now.
Yeah.
Yeah.
Yeah, as I say, I mean, in some point, what Dr. Jaya says is you can see from that perspective.
Right.
Okay, I just want to comment about the difference between private
Yeah.
and corporate.
Okay, go ahead.
See, at one
Corporatizing.
time when I was actually in UMMC,
Yeah.
we want to be corporatized, not because of anything.
Right.
We want to improve efficiency.
Sure.
Okay, you see, if you don't, you see, when you talk about running the hospital, you must get the right person to run the hospital.
Okay. Oh, absolutely agree.
Okay,
I
so I do not want to comment how the people become head of hospital at the moment in the public sector. I don't think I'm the person to. But what I'm trying to say, if that sort of thing happen, we want to increase efficiency, okay, and like what there shouldn't be any misdiagnosis and so on and so forth.
Yeah.
Whatever that you have, everybody got to agree, right? So that's why it goes back to something that we should can follow. Okay, I can use Singapore as an example.
Okay.
Singapore as an example. Okay, yes, all the hospital are corporatized. Even for the government, they are
Yeah.
corporatized. Not because of anything.
Right.
They still control and so on and so forth. Control brain drain, blah blah blah.
Sure.
Okay, they tried that, right? But at the same time, I think most important thing is that we cannot take things for granted.
Okay.
Meaning that because in our system, all right, we have everything centrally. When it's centrally, it's very difficult to make decisions, and you can see all the bureaucracy coming in,
Yeah.
and you cannot make. I give you a very good example when I say like this. I'm sure we have experience in other countries where we look into the emergency and trauma sector.
Yeah.
In their system, when the patient came in into emergency, and the whole purpose is actually to treat.
Okay.
Right?
Yeah.
Treat. Yeah. But you look at our A&E. Our A&E got green lane.
Green. Yes.
Right? And that's not even, I mean, we can discuss this.
Yeah.
But by right, all this shouldn't be in hospital. Dr. Jaya can correct me.
Yeah.
A definition of a hospital is a hospital. Actually, it's an inpatient.
Sure.
No, it's not outpatient. The outpatient is different altogether, you know.
Right.
Yeah, outpatient lah.
Yeah.
That's why I have my own mind
Yeah.
about ambulatory services
Sure.
and so on and so forth, right? But to me, because I've been in that experience for many years, a hospital is a hospital. The outpatient should be out of the hospital.
Sure.
You
Yeah.
know what I'm trying to say?
Yeah.
So that because part of it is actually congestion.
Yeah.
All this will affect staff morale and so on and so forth. And you can see we have problems with parking and so on and so forth.
Yeah.
So what I'm trying to say is why we don't have a system, a proper integrated system.
Yeah.
One,
Right.
primary care, secondary care,
Right.
and tertiary.
Yeah.
Irrespective,
Yeah.
if you want to call still a public
Yeah.
or a private, I don't care. Because the healthcare financial mechanism will be to cater for the cost and so on and so forth.
Okay.
So I again say that, when you talk about corporatized, it's very different from privatized.
Yes. True.
Privatized is different,
Yeah.
right? Corporatized is to make sure that I can get a salary
Right.
within a corporate, but the running of the corporate is really
Different.
superb.
Okay.
Very all accountable and so on.
So what I'm going to do for you when you're watching this is I'm going to do a series of very short videos on primary care, secondary care, tertiary care, just to explain to our viewers what's the difference between that and the systems that we're talking about here. We're just throwing some words out. People may not understand it, so I want to be clear about that. But very quickly, Dr. Jaya, we want to go into that second and third points. There's three key points. One was Rakan KKM. We've really sort of merged into healthcare financing. The second point, and maybe very quickly on the third point that you're talking about the brain drain and how do we solve that? So maybe you
I already covered that, talking about the moratorium.
Yes, the
I
moratorium.
talked about that. And I'm talking about the other one is raise the funding to 5%.
Yeah.
I've already covered that. But I want to talk about, he's talking about how to bring the GPs into the system.
Okay.
I don't think we need to have social health insurance or to corporatize things to bring GPs in. You know what we are suggesting, we meaning PSM,
Yeah.
together with the People's Health Forum. What we're saying is we should have a pilot project where we get some willing GPs in some districts to take on what we call NCD patients,
Non-communicable diseases.
diabetics, hypertensives, and tell these patients, look, you go and see the GP, you don't have to pay anything.
Right.
GP will be paid per capitation. That means you are paid for that patient.
Right.
Whether he comes or not that month, you're paid for him.
Okay.
If he comes 5 times also, you still pay the same amount.
Okay.
Medicines the government will supply.
Okay.
Lab tests the government will do.
Yeah.
So you get GPs to take on such patients.
To manage the patient.
To manage the patients.
Right.
So we have maybe 100 and 150 diabetic patients.
Yeah.
They can then employ a nurse.
Right.
To be an educator, nurse educator for these patients. Talk
Sure.
about their diet, talk about, food care, talk about the medications. And so you can do that. See, then the quality, of your healthcare will go up.
Yeah.
And these patients, we can induce them to come into here by saying that, look, if you go here and don't go to the government, you go here, everything is free. You have personalized care.
Yeah.
And if this GP refers you to government, you have a special lane.
Ah,
You see
okay.
specialists fast
Yeah.
because you're going through the system. So you go back to the primary, what Cuba is doing, or what
Sure.
even UK is doing. You
Yeah.
go back to a primary healthcare system. So people don't just simply, like now in Malaysia,
Yeah.
you just think, oh, I got a chest pain, I think I want to go and see a cardiologist.
Yeah.
I got a headache, I want to go and see a neurologist. It's very expensive. You should be seeing a primary care person
Right.
who acts as a filter, as to find out exactly what's your problem,
Yeah.
So I think that is one idea we can start, We can
Yeah.
start doing it even now. Only thing is, this means money. It needs a bit more money to pay the GPs.
Right.
So they should do it not nationwide first, do it as a pilot study,
And how long should a pilot study like this be? 6 months or 2 years?
maybe 6 months to 1 year. Then you see how it runs. Then you see what are the teething problems.
Okay.
Then you expand it. And you got to see how to get so that means you decongest your hospital
Right.
on one side. Second is you provide more personalized care for diabetes and hypertension.
Sure.
Third thing is what we can do is we can actually do SOPs. A GP should do a cholesterol level or
Sure.
HB1C
Actually,
level,
A1C level.
A1C level and all that. How often?
Yeah.
And then we can say, if your HbA1c on the average is less than so much,
Yeah.
we'll give you a bonus.
Okay.
If your the number of patients on your follow-up, the obesity rate is lower,
Right.
we'll give you a bonus,
Okay.
We can do
So there's
something.
an incentive there.
Incentive, so we can actually improve our healthcare. I think our healthcare of our NCDs
Yeah.
isn't good enough, because in the government side, they're really rushed.
Yeah.
And you don't see the same doctor, and then you forget, have I done this guy's eye test, retinal check, have I checked
Never.
his kidney or not?
Never.
I mean, they do it, they try to, but the thing is, when you're seeing different doctors are seeing, you lose touch, you see.
Yeah.
So I think this is something we can do to
So
improve the
this
system.
is where my criticism of the system is: we haven't invested in it other than our hospital. And what I mean by that is the infrastructure at the back. Our digital system is not there. And I'll give you an example of this. I suffer from diabetes because of my transplant medication, right? You know that. And when I lived in the UK for a couple of years, immediately I went for an eye checkup because they said, we've got you in the list here as a diabetic. Every year you have to go and do a test.
Yes.
So I went there and I did a test. Now, since I've been back 5 years, it's not happened.
Are you seeing
And
the government side? You're seeing the government side?
Yeah, I'm seeing the government side.
Okay.
I'm taken care of by HKL. And I mentioned it to a doctor a couple of weeks ago, and she said, oh, yeah, because it's a whole different department. The system is so siloed. I go to this doctor in this system, it doesn't talk to anything else. And that is why. So it doesn't take care of the patient. Because the patient could have different comorbidities, right? So I'm a transplant patient. I've also got diabetes. So I should be taken care of so that it's managed, so that it doesn't get worse. So I don't have eye problem. And eventually I have to do more things. And I'm going back to the health system. And it's costing them more because the prevention is not there, the screening is not there. So these are the things that my criticism of the system is always been, we don't have this data. We don't know patient A has this, patient B has this. How many patients do we have in total? Diabetes, X amount. You're talking about NCDs, right? Obesity, diabetes, huge number.
Really 30%. I think.
Okay, so if you say 30% of the population, 9 million or 3 million, 3 million. Are we doing 3 million tests a year for diabetes? Are we? How many diabetic retinopathy eye tests are there here? If you're doing 10,000, say 3 million patients. We're missing so many. So again, this is the data that we really need to look at and say, because all these people who are diabetes will get to this if you don't take care of them, right? So my criticism has always been, we didn't invest years ago.
The thing is, that's the thing. We are chronically underinvesting. Certain things like checking eye pressure and looking at the back of the fundus, and you see anything abnormal, taking a photograph, you can train a paramedic to do it very well.
Really?
Of course, the paramedics are doing echo now. For example, you go to IJN, any place, they're doing very good echoes. They're doing the stress tests.
Right.
So you don't need to kind of say you only need a specialist. You see.
Right.
The thing is, to decide after that, what do we do? Do you give an injection to the eye, or do we do a laser treatment? Maybe that judgment is different. But the screening, that can be done by paramedics but they need enough equipment, that proper equipment. And you see something wrong, they can take a photo and just show it up, and then you can discuss it. Is it?
Yeah.
So these are the things that we can do if there's funding.
Right.
The problem is really lack of funding. It's chronically underfunded.
So, we need to wrap this up. Final question to both of you guys. What do we need to, if there's one thing from you guys, what do we need to do to get us out of this? I'm not going to say rut. We're not in a rut, but we need to move forward from this. Since independence, we haven't really, lifted out. We look at our neighbors and say, hey, they're doing better than us, right? What do we need to do? You want to go first? Yeah.
Yeah, I think as I say, we haven't changed our healthcare system right during independence and so on. My wish list will be integrated, because at the moment, when you have the public and the private, we have 6 sectors.
6 sectors.
Because we have tertiary care, secondary care, and primary.
Right.
We divide into 2. We got 6 sectors.
Okay.
All right. So we still need to integrate.
Okay.
So become 3 only.
Yeah.
Primary, secondary, and tertiary.
Yeah.
And then we can have this payer that I mentioned earlier.
Yeah.
Okay.
Yeah.
Whoever give the services,
Yeah.
get paid.
Okay.
Okay. For example, if you look into, you see what the government is doing, I mean, it's not wrong, no. What I'm trying to say, they try to do this within their setting.
Sure.
The KK supposed to be primary,
Right.
okay?
Clinical center.
And the KK, the
Yeah.
clinical setting, right? And so on and so forth, right? And also in the private.
Yeah.
But in private, there's no control at all. There's no real control at all.
Right.
Everybody is on their own.
Yeah.
We can talk about this. So I just want to get people to understand the role of pharmacists then.
Yeah.
Okay, when you look into the whole thing about health, right? All right, at the moment you only focus on curative, you are fully focus on rehabilitative, and we only focus on palliative.
Yeah.
All these are all sick care,
Yes, they are sick care.
They
Yeah.
are sick care, right?
Yeah.
My wish will be on the other side, and it's been actually targeted in the health white paper.
Right.
You have to go into promotive care and preventive care because I want people, Malaysian, to be healthy
Yes.
along the way.
Yeah.
So as far I can only say for the pharmacists, yeah.
Yeah.
So we have actually telling the government, please recognize the role of pharmacists in this country.
They should.
Yes.
No,
Now, I mean, as far in the public is fine.
Yeah.
All right.
Yeah.
But when you talk about private,
Yeah.
please recognize that community pharmacists
Yeah.
are not drug sellers.
they're not.
They are not drug sellers.
Yeah.
Say like Dr. Jaya says, now with all the technology and now the patient wearing wearable and so
Yeah.
on, what are we talking? So, from the pharmacy perspective, we have actually changed the whole thing. There's no such thing as retail pharmacy. The word retail pharmacy doesn't exist anymore.
Okay.
We are talking about community pharmacies.
Right.
Okay, and now the focus on health. All right, how people in the community be healthy and stay healthy, and so on and so forth.
Absolutely.
Right?
Yeah.
So okay, you talk about screening, for example. You see, the pharmacies all over the world, we are doing all this.
Yes.
When you
yes.
talk about screening.
Yeah.
So if the patient can wear wearables,
Yeah.
we actually can help to educate the public. Okay,
Okay.
look, we are not diagnostic. The
Yeah.
pharmacists will not diagnose. It's not their work. All
Yeah.
right, but we're able to help. All right, when we do this, then we can actually refer. So as far as this is my wish,
Yeah.
meaning that the government got to recognize GP
Yeah.
and also recognize cooperative pharmacy. We have a role to play.
Absolutely.
All
Because it's the ecosystem.
Yes,
it is the ecosystem.
ecosystem. So now you can see, all the thing. Because I will not mention about about all these fighting and so on
Yeah.
between both professional
Yeah.
and also in terms of which I don't want to discuss.
Yeah.
But I think for the sake of the country, for example, I've actually reached I said 80 age person, isn't it?
Right.
I want to stay healthy.
Right. Of course.
So who going to educate me?
Sure.
We need professionals to educate,
Yeah.
Okay, so that's why as far as medicine is concerned, drug is concerned, we are trained in that area.
Right.
All right, just because that we are trained and so on and so forth. Of course, the doctors will go into diagnosis. It's fine.
Right.
But as far as medicine is concerned, this is where we are trained. So if they can recognize and so on and so forth, and whatever services that we give, I give you a good example, Dr. Jaya. Okay, you talk about we mentioned about diabetes, just an
Yeah.
example, right?
Yeah.
Do you know there's the term pre-diabetes?
Yes.
Exactly, we can play that role.
Yeah.
So we can actually prevent already
Sure.
going into diabetes. So this one of the thing that the
I
pharmacist
fully
can.
support that. And the reason I support that is from the patient's point of view, we don't want to fall sick. We want to be well. Do we know how to stay well? Is our education system teaching us all these things? We don't do that. And I have very good friends who are pharmacists that I talk to all the time. So that is that, keeping yourself healthy and doing that. So, doctor, your final thoughts on, what's that one thing that you wish for?
Okay. I think, we've got to recognize what a gem our public healthcare system is.
Yeah,
It's
it is.
what that makes Malaysia a caring society. It's,
Yeah.
it's one aspect of it.
Yeah.
And I think we got to recognize that a lot of dedicated people there
Yeah.
doing a lot of hard work.
Right.
So I think we got to appreciate that first of all.
Yes.
When I criticize the healthcare system, I criticize the individuals there. I'm criticizing the fact we're not supporting it enough.
Yes.
That's the first thing. Now, improvements How do you drive improvements in a system? Do you go on the materialistic basis that do you go to people's, do you have commercial kind of, you pay you more time, you go monetary? Or you see, you look at human beings, huh? Human beings have got a self-centered aspect to them. That is there, definitely.
Yeah.
But at the same time, there's also an altruistic aspect in human beings, which is
Sure.
very, very deeply wired,
Yeah.
You must remember, as a species, until the advent of agriculture about 10, 12,000 years ago, we were small hunter-gatherer communities,
Sure.
And what made certain communities survive is that the fact they could look out for each other.
Right.
They look out for the weaker ones, look out for the children. The fellows who are too selfish would all be eaten up by the saber-tooth tiger or something,
Yeah. Yeah.
Only those guys who hung together and sacrificed and
Right.
fought for each other. So that thing is actually wired into our psyche,
Right.
And that's why religions all go for solidarity. Which religion says, go for profit,
Yeah.
become selfish, become rich? No. Religions always say be humble, share, look
Yeah.
after the weak.
Yeah.
That is deep in our psyche. So we should use that feeling for solidarity
Right.
to also shape our institutions, whether
Sure.
it's education or healthcare or welfare or whatever,
Right.
instead of going on, it's a human economicus,
Right.
throw money at the
Yeah.
fella and the fellow will act. I mean, if you do that, more people will act like that, but they won't feel happy with themselves.
Yeah.
People will feel happier if they are in a community that has solidarity, looking for each other. People feel better about it.
Sure.
So I think this whole thing of going towards commercial, corporatizing,
Right.
money, DRG and all that is going against what is there in human nature.
Hmm.
It's going against our religions.
Right.
I'm not a religious person, but but
Yeah.
the religions reflect what's there in our psyche, you see?
Sure.
And I see it's there because of our evolution. Those communities that were selfish died out.
Yep.
Only those who hung together and fought and stayed and protected the weak and made sure the children came up, the women who looked after and all that, those tribes survived and became civilizations we know.
Yeah.
So it's in us.
Yeah.
Someone's saying something new,
Right.
So, so I think we should build our institutions based on solidarity
Okay.
instead of going on commercializing everything.
Sure.
And that's why I'm unhappy with the Maharani government, because it think can throw money at things.
Right.
You shouldn't. I mean, of course, you must pay your health people better.
Sure.
We're asking for we've been asking for a separate health commission.
Okay.
So your doctors, your nurses, your paramedics, your radiologists all get different pay. Maybe you follow the IJN system. You're asking for that.
Okay.
But at the same time, the solidarity thing must be built up, you see.
Sure.
And to do all of this, you got to increase the health budget
Sure.
to 5%
Okay.
of the GDP. That's what we're asking for.
That's it. Thank you. Thank you so much, both of you, for a fantastic, riveting conversation. And one of the things I want to make absolutely clear is I'm a product of our public healthcare system. And I do go to private hospitals when I have to. But I'm a product of the public healthcare system, and I know numerous doctors, that I've dealt with over the 25 years that I've been a patient. And their work ethic, their passion, fantastic. And if there's a criticism from them, it is the system has just disregarded them. So the harder they work, they don't get anything at the end of the day. And as you grow older, you wonder, can I feed my children? Can I send my children to the universities? Can I do all these things? And they can't. So some of them are forced to go to private for the money. And so money does make the world go around. But I totally get what you're trying to say, because so many of them, they are really, really good people that I've met, who would literally die for a patient. They will do everything they can for the patient. But sometimes I have to ask the question, is the system, does the system really know what's going on down there? Does the system really realize that a patient like me is walking into the hospital and I have no clue what the heck's going on, because I just felt sick today, but I had a heart attack, whatever it is, and now I'm in the system and I'm waiting and I don't get the care and I have to wait too long, and then it progresses and then you lose that person. So that's not good. So I'm all about saving people's lives, and I understand there's so many people who are good people or in the system. So if anything, I think we want to make it clear that the system needs to improve, change, do whatever it needs, because they are really good people, and they're even better people who deserve that healthcare. And healthcare is not about money. Healthcare is a human right. It needs to be delivered to the people. And a healthier nation means a prosperous nation. We can all agree on that. So thank you very much. Thank you very much, Dr. Jeyakumar. Thank you very much, Prof. Always wonderful having you all here on Healthcare Simplified with Manway Richter. We'll be back with more soon. Take care. Say bye.